Let's review retinal vein occlusions. A retinal vein occlusion occurs in the setting of increased retinal venous pressure and reduced blood flow through a retinal vein, leading to retinal hemorrhage, edema, ischemia, and vision loss. The central retinal vein travels alongside the central retinal artery within the optic nerve, sharing an adventitial sheath as they pass through the lamina cribosa. When blood flow through the vein is reduced, a central retinal vein occlusion, CRVO, occurs. The entire retina is affected. Branch retinal vein occlusion, BRVO, occurs when flow is reduced in one of the intraretinal veins, typically at an arteriovenous crossing point. A sector of the retina is affected. In hemiretinal vein occlusion, HRVO, the occlusion occurs in a vestigial bifurcation of the central retinal vein behind the lamina cribosa, affecting either the superior or inferior half of the retina. The retinal artery and vein share an adventitial sheath. Atherosclerotic changes to the artery compress the distensible vein, leading to the cascade of venous stasis, flow turbulence, endothelial cell damage, and thrombus formation, resulting in venous occlusion. Shown here is a retinal artery compressing a retinal vein. Venous occlusion induces retinal ischemia from capillary non-perfusion. The retinal ischemia triggers inflammatory cascades, which release VEGF, inducing vasopermeability that results in retinal hemorrhages and macular edema. Shown here is an OCT of an unaffected right eye compared to an OCT of the left eye, with a BRVO causing macular edema. Common sequelae of retinal vein occlusions are retinal ischemia, macular edema, neovascularization, vitreous hemorrhage, epiretinal membrane, retinal traction, and retinal detachment. A central retinal vein occlusion can also induce a cilioretinal artery occlusion. Over 90% of CRVOs occur in patients over 55 years old. Risk factors for CRVO include hypertension, hyperlipidemia, diabetes, and open-angle glaucoma. Hypertension is present in up to 73% of patients over 50 and 25% of younger patients. Hyperlipidemia is present in 35% of all patients. Diabetes is present in 10% of patients over 50, but is rare in younger patients. Oral contraception is a risk factor in young female patients, especially those with thrombophilia. Patients with myeloproliferative disorders, hypercoagulable states, and inflammatory disease are predisposed to CRVO. Risk factors for BRVO include hypertension, open-angle glaucoma, cardiovascular disease, and high body mass index, not diabetes. Patients typically present with acute central or peripheral monocular vision loss. Transient or asymptomatic vein occlusions are less common. Rarely, patients present with floaters from vitreous hemorrhage after asymptomatic BRVO. Exam should begin with an undilated anterior segment exam and gonioscopy to look for neovascularization, followed by dilated fundoscopy. Classic presentation shows dilated and tortuous veins, intraretinal hemorrhages, cotton wool spots, and ghost vessels. The retina is often described as having a blood and thunder appearance. Optic disc edema, macular edema, and subretinal fluid may be present. Chronic findings could include retinal choroidal collateral vessels, optociliary shunts, capillary non-perfusion, sclerotic vessels with atrophy, and iris and retinal neovascularization. CRVO fundus findings depend on the degree of outflow and amount of collateral vessels. CRVO can be classified as perfused or non-ischemic and non-perfused or ischemic. 75% of CRVOs are non-ischemic, perfused, due to collateral vessels. Vision loss will be 2200 or better. RAPD will be absent or mild. Exam will show venous dilation and tortuosity, dot blot hemorrhages in 4 quadrants, especially in the periphery, optic disc and macular edema, and some cotton wool spots. Conversion to ischemic CRVO occurs in 15% of cases in 4 months and 34% of cases over 3 years. Ischemic, non-perfused CRVO presents with more severe vision loss, worse than 2200, and marked RAPD. Exam will show severe tortuosity and dilation of all branches of the central retinal vein, extensive hemorrhage in the periphery and the posterior pole, and severe disc and macular edema. Ischemic CRVO can cause profound vascular leakage. Rubiosis iridis develops in 50% of ischemic CRVO eyes between 2 to 4 months. There is a high risk of neovascular glaucoma, and retinal neovascularization occurs in 5% of patients. BRVO is the most common type of retinal vein occlusion and can be classified as major or macular. A major BRVO is an occlusion of a vein that drains one of the retinal quadrants. The superotemporal quadrant is most commonly affected, 58.1 to 66%, followed by the inferotemporal quadrant, 29%, and the nasal quadrant, 12.9%. Major BRVOs will cause a peripheral field defect corresponding to the quadrant affected. A macular BRVO is an occlusion of a venule in the macula. The superior macula is affected 81% of the time compared to 19% for the inferior macula. Macular BRVOs cause a central visual defect. Shown here is a superior macular BRVO. The arrows point to a sclerotic artery compressing the underlying vein. BRVOs can also be described as non-ischemic or ischemic. On a BRVO exam, there will be a wedge-shaped distribution of retinal hemorrhages that are more extensive in ischemic BRVOs compared to non-ischemic BRVOs. Differential diagnoses to consider are ocular ischemic syndrome, HIV retinopathy, hypertensive retinopathy, and hyperviscosity retinopathy. Fluorescein angiography is useful to determine the degree of ischemia and predict the prognosis and likelihood of developing neovascularization. Non-ischemic CRVO will demonstrate delayed AV transit time on FA. This FA highlights many retinal hemorrhages blocking fluorescence from the choroid. The retinal arteries and capillaries are perfused, and the retinal veins have not yet filled. Moderate to severe CRVO will cause late staining along the large retinal veins. A normal FA will show peak fluorescence around 30 seconds. Here you can see that at 27 seconds, the veins have still not filled. At 37 seconds, the large retinal veins begin to fill. Ischemic CRVO will have extensive capillary non-perfusion. Greater than 10 disc diameters of capillary non-perfusion indicates an increased risk of neovascularization. This angiogram shows almost total non-perfusion of the capillary bed, indicating ischemic CRVO. OCT is useful in monitoring the development of macular edema and its response to treatment. Common OCT findings include cystoid macular edema, intraretinal hyperreflectivity from hemorrhages, shadowing from edema and hemorrhages, and occasionally subretinal fluid. Disruption of the ellipsoid zone after resolution of macular edema indicates photoreceptor cell death and poor visual acuity. This figure outlines a normal ellipsoid zone in photo A, then demonstrates a normal, patchy, and absent ellipsoid zone respectively in photos B, C, and D. For older patients with cardiovascular risk factors, no laboratory tests are needed. In atypical cases, such as young patients or bilateral or recurrent RVOs, labs are indicated to find an underlying cause, such as hypercoagulability, inflammatory causes, or renal hypertension. Primary prevention of retinal vein occlusion is control of risk factors, which includes managing high blood pressure, hyperlipidemia, diabetes, and glaucoma. There are currently no treatments available to reverse a retinal vein occlusion, so the best treatment for RVO is managing the sequelae, like macular edema and neovascularization, to prevent further vision loss. First-line treatment for macular edema is anti-VEGF injection. If the macular edema persists despite anti-VEGF treatment, Second-line treatment is with steroid injection or implant. Neovascularization is treated with anti-VEGF injections. After identification of iris neovascularization, the retina should be promptly treated with panretinal photocoagulation, PRP. Grid laser is appropriate only for macular edema with BRVO. In the case of vitreous hemorrhage covering the macula, a vitrectomy may be performed. Following the acute event, patients should be examined on a periodic basis to monitor for neovascularization. The risk of rubiosis is highest in the first 90 days post-occlusion and decreases through 6 months. This progression is delayed if the patient receives anti-VEGF injections. CRVO eyes are examined monthly for 6 months before extending visits. Prognosis after RVO depends on the location of the occlusion, the degree of ischemia, and the development of sequelae. The main cause of poor vision after RVO is chronic macular edema. Non-ischemic CRVO has a good prognosis with vision returning to normal or near normal in 50% of patients. Ischemic CRVO has an extremely poor prognosis. Prognosis can be estimated based on the initial visual acuity. If the patient presented with 20/60 vision or better, the visual acuity is unlikely to worsen. If it was 20/80 to 20/200, the visual acuity could improve, stay the same, or worsen. If the vision was worse than 20/200, improvement is unlikely. Prognosis is better for BRVO. 50 to 60% of patients have a visual acuity of 20/40 or better. Vision improves in 1/3 to 3/4 of BRVO patients by at least 2 lines. Macular BRVO, chronic macular edema, and neovascularization will produce worse outcomes. In summary, retinal vein occlusions occur when outflow through a retinal vein is reduced, leading to retinal hemorrhage, edema, ischemia, and vision loss. Patients typically present with acute central or peripheral monocular vision loss. Exam should begin with an undilated anterior segment exam and gonioscopy to look for neovascularization, followed by dilated fundoscopy. Classic presentation shows dilated and tortuous veins, intraretinal hemorrhages, cotton wool spots, and ghost vessels. The retina is often described as having a blood and thunder appearance. Optic disc edema, macular edema, and subretinal fluid may be present. Chronic findings could include retinal choroidal collateral vessels, optociliary shunts, capillary non-perfusion, sclerotic vessels with atrophy, and iris and retinal neovascularization. Central retinal vein occlusions affect the entire retina and are classified as ischemic, non-perfused, or non-ischemic, perfused. 75% of CRVOs are non-ischemic due to collateral vessels. Hemorrhages will be present in all 4 quadrants, especially in the periphery. Vision loss will be 20/200 or better. Conversion to ischemic CRVO occurs in 15% of cases in 4 months and 34% of cases over 3 years. Ischemic, non-perfused CRVO presents with more severe vision loss, worse than 20/200, and marked RAPD. Hemorrhages will be extensive and involve the posterior pole. Rubiosis iridis develops in 50% of ischemic CRVO eyes between 2 to 4 months. There is a high risk of neovascular glaucoma, and retinal neovascularization occurs in 5% of patients. BRVOs are more common. They are classified as major or macular. A major BRVO is an occlusion of a vein that drains one of the retinal quadrants. Major BRVOs cause peripheral field defects. Macular BRVOs occur when a venule draining the macula is occluded, resulting in a central field defect. BRVOs can be further divided into ischemic or non-ischemic vein occlusions. Fluorescein angiography is useful to gauge the extent of perfusion and leakage and to identify retinal neovascularization. OCT helps monitor macular edema and guide treatment. Treatment for RVOs is to manage risk factors such as hypertension, hyperlipidemia, diabetes, open-angle glaucoma, cardiovascular disease, and body mass index, and to manage sequelae like macular edema and neovascularization. First-line management for macular edema and neovascularization is anti-VEGF injections. Prognosis varies from 20/40 or better in roughly half of patients with BRVO to extremely poor prognosis, 2200 or worse, with ischemic CRVO. Thanks for watching. If you found this review useful, please like this video and subscribe for more content. If you'd like to see more reviews like this, consider becoming a Patreon supporter. Until next time, happy studying.